And we missed all the fun. We didn't get all that. We didn't get all the fun recorded. Then I'm so sorry.
Well, no, that's good for people who want to listen, who didn't attend. They don't have to sit through that.
Well, for the record, we all want to wish Len happy birthday today. How many years is it, Len?
I'm only going to say it in Italian. If you don't know it, that's too bad. Sessanta nove.
Okay, I got it. I'm not I'm not compromising myself here by reading it in English.
I won't tell. I won't tell either. Even though Facebook tells you loud and clear how old you are.
Oh, that's true. That's true.
And all I can say is we better be planning a party for next year, Len.
A party.
Yeah, big party.
Oh, yeah, that's a big one, right?
And someone just joined us on the telephone.
That's the man.
Hello, Sylvester.
Hello, everybody.
Hi, Sylvester.
Hi, Sylvester.
Hi.
Okay.
Trying to find here he is.
So let me run down the list, and then we'll go from there. We've got Sylvester Mann, Jake Hannum, Peter Kafka, Larry Burke, Brian Heisey, David Sibley, no Ken Mason, Dennis Correa, Eric Bookbinder, Jay Curran, Jay Krutman, Gigi and Dan Roten, Paul Frieda, Gary Gunville, Scott Schreff, Jim Harrington, John Appler. Did I miss anybody? Oh, Bill Franklin, I see. I see Bill Franklin's with us too.
Good evening,
Yeah.
Bill.
Good evening. Is this the Rick and Len show?
Yeah.
Rick and Len and Jake.
Yeah. Anybody else? Did I get everybody's name?
Did you mention Sylvester?
Yes, I got Sylvester. I mentioned Sylvester.
Okay.
So, what we have one new gentleman, and what we normally do, Larry, when we have somebody new, is we give you the floor up front, and if you are willing to take it, and we want you to tell us a little bit about your background, your age, your disease demographics, where you're being treated, and really what your key issues are for your future treatment, and then we will add it around a little bit here and see if there's any way that we can help you a little better. So why don't we move forward if it's okay by you?
The answer is yes, Rick. Do me a favor, though. I'm going to read this. It's going to be fairly brief.
Okay.
But I want to make sure that you can hear it. So if not, let me know.
Okay. Well, we hear you loud and clear right now.
Okay, very good. I was newly diagnosed with stage 4 prostate cancer, and I would like input from those who have received the same diagnosis. I'm 74 years old and until last month very active. Biking, brisk walking, weights, at least one activity every day, never smoked or drank, and a healthy diet, pretty much vegetarian. All this changed overnight in mid-February after years of what I thought was BPH and urinary retention. I wound up in the ER with a total urethral obstruction. So I was not voiding any urine at all. This led to visits with a urologist and a diagnosis of stage 4 prostate cancer on February 23rd. So it's about 23, 24 days ago. My PSA is 18, my Gleason is 9. All samples were positive. Half were a 4+5 Gleason and half were a 5+4. Local scans show metastasis to the bones with multiple lesions on both femurs, iliac, and sacral bones. Body scan shows metastasis to the ribs and lumbar spine, and CT of chest and abdomen show lesions in lungs. I wish there was some good news in here, but there isn't any. When I first heard this diagnosis and these test results, I thought I had about a week to live. After reading extensively online, including posts on this site, I'm more hopeful. My MO tells me that the median survival for men with the same diagnosis is 3 to 4 years. But one online source reported lower by half median survival times. But quality of life is as important to me as survival time. Fortunately, miraculously, I'm not having any pain, and pray I'm one of those lucky ones that will not have, a lot of pain. To give you medications, I was on bicalutamide for 2 weeks, if that's how it's pronounced,
Mm-hmm.
and then received a 1-month injection of Lupron about 7 or 8 days ago. The bicalutamide was discontinued 1 week after the Lupron injection, which was the day before yesterday. On April 9th, I will start injections of Zytiga plus prednisone. My MO encouraged 6 courses of chemo, but then said that having it would significantly increase survival, but could have some, very deleterious side effects. So for now, I'm skipping it. On top of all this, I've had to catheterize myself 4 times a day, and my wife are reeling. We've gone from total devastation to severe depression. And any realistic encouragement, and certainly not false encouragement, and information about treatment for those that were similarly situated would be greatly appreciated. I'm going to write in.
Okay. Where are you being treated, Larry?
2 places. I live in North Carolina. My MO is part of Duke. And I have a surgical oncologist that is part of UNC. He is the head of urinary oncology for UNC.
Mm-hmm.
I can mention the names, but I'm not sure that's pertinent at the moment.
No, the names are important. Who's your medical oncologist at Duke?
Ramalingam is the last name.
And is this
young guy? I can send you the information.
Yeah.
But supposedly the top of the game.
Well, we'll talk about that. We'll talk about that momentarily. But is he a genitourinary medical oncologist, or is he just a general medical oncologist?
Urine.
He is
the first that you mentioned. Yes.
He is a genitourinary medical oncologist. Okay. I know some of the guys there. I haven't heard his name. He's probably a young guy.
Yes, he is.
But I'll come back to that. And who's the surgeon at UNC?
Wallen, Wallen.
I don't know him either.
First name Eric.
Okay. So the good news is that you're seeing. It sounds like you've got the right team of doctors, in the sense that you have a genitourinary medical oncologist, and most of the information that you've given us sounds pretty accurate, pretty correct. Including but not limited to the prognosis, which they typically will say is 3 to 5 years. But you'll find that there are guys on this call who have been diagnosed similar to you, who have already outlived that. So every man is different, and we'll get in some detail to the right things and the wrong things to do. But I think the first thing that I would really like to do, because you were diagnosed through a urinary obstruction, is I'd like you to talk to Peter Kafka, because he has a lot of experience on this, or with this. And while he was diagnosed also 4+5, but without metastasis, although now his disease seems to be progressing a little bit, he did have surgery. Is Professor Bill on the call? No, he's not. Yeah, we have another guy that's regularly on our call who's been self-catheterizing for years. And it seems like that the big issue with that, and Peter can say more, is that you have to be very careful around urinary tract infections. It's very easy to get a urinary tract infection. And
Well, the answer to that, not that I have a full answer, I spoke to friends of mine that are oncologists, and I have a procedure where I go through. I mean, there's iodine, there's
Right.
BTK wipes, et cetera. I mean, it's
right,
I can't say it's totally germ free, but it's not one of these casual things.
right.
I mean, every time I call it a ritual.
No, I hear you, and I think, unfortunately, Bill isn't with us just yet. He may be on, but he himself is a cancer research scientist at a major NCCN hospital, and he's been pretty careful over the years, but it's still hard to avoid. It's an occupational hazard. But Peter, talk to Larry a little bit, at least around the obstruction issues, and then we'll move into the chemo stuff. I'm sorry, I shouldn't have said that, into the more advanced treatment and the issues around chemo. I beg your pardon.
Sure. Your name is Larry?
That is correct. Yes, and you are.
My name is Peter Kafka. I'm over in Hawaii, so I'm 6 hours behind you. Without taking up a lot on the call, let me give you my telephone number, okay?
Yes.
You have a pencil there?
Yes, I do.
808-298-1655.
Let me repeat that. 808-298-1655. And if I had an address, I would stop by.
Well, seriously, give me a call. Remember, I'm 6 hours behind you. But anyway, let me just briefly. I was diagnosed 4 years ago. Same kind of story. I had convinced myself I had BPH, and I think we need to go out and stalk and beat all the guys over the head that think they have BPH and make them get a biopsy and really check this out. Because I had urinary symptoms and I was stupid and didn't get it checked out. And sure enough, I was a Gleason 9. Mine had progressed to the seminal vesicles. It hadn't escaped the now has. So the likelihood of micrometastasis is all over the problem. Anyway, so I'm not as serious as you, but I was on a catheter for 8 months. I never got a urinary tract infection. I was careful with it. But the thing I did was I had surgery. And that might not be, or it might be appropriate for you. I had surgery with what I considered one of the world's top surgeons in San Francisco at UCSF, named Dr. Peter Carroll. And he couldn't guarantee me anything, but I came out of surgery continent and able to urinate, and I've been that way ever since. So to me, that was worth the price of admission. It changed my life considerably, even though I still have, advanced prostate cancer, but I can deal with that. But it
Yes.
changed my quality of life considerably. I don't know if that's appropriate for you, but you might want to talk to surgeons. In your situation, it's considered debulking. That's what it was for me, total debulk. But it freed up the tumor that was pressing against my urinary tract.
Just to give you a little more background, the surgeon who recommended, first of all, I had a Foley catheter, which was the most horrendous thing. It was as if I had a torture. I had that for 10 days.
So, I know. I had it for 3.5 months. Tell your wife she deserves a medal for putting up with it. My girlfriend does.
Yeah, I was not a happy camper. However, my surgeon now said that if I do this for 3 to 4 months, because he said right now my bladder, which was overextended somehow, he said it might, and I catheter 4 times a day, it might reconstitute itself, if that's the right word. So he's telling me time will tell. I have a, and I don't know the procedure, but it's something that will, in June, that will tell me if my bladder has reconstituted itself. Based on that, I might have surgery. So I have not, my goal is to do what you did. In other words, to get back to what I would call normal urination.
Give me a call sometime, and I'll be glad to talk it over with you. I don't want to take over the whole meeting with this, but there's lots we can talk about.
I appreciate that, and I will do that in the next day or two.
Great.
Thank you.
Dennis, you were diagnosed metastasis, correct?
Yes.
And how long ago was that?
That was about 18 months ago.
Okay. And you want to talk a little bit to Larry about your situation and how you're doing now and what you've done, etc.
Sure. I guess the first thing I would tell you, Larry, I'm 72 now. And I think I was 70 at diagnosis, October 16. But I had a struggle with first identifying where do I want to get my treatment. At that time, of course, I was pretty depressed, and this was a kind of a really earth-shattering thing for me to accept what I had. But I had a Gleason 9, and I had my PSA at that time was, I think, around 17 or so. It was the same thing, and I was getting routine. I had no symptoms, just getting routine PSA checks, part of my annual physicals. And this came about, and then turned around and got the biopsy, and then went from there to getting the scans done. And my mets were all of my spine and my femur, and I had no other soft tissue other than lymph nodes, pelvic lymph nodes involved with a Gleason 9. But then I make the decision about getting my treatment, and you want to feeling terrible, then do I want to go halfway across the country to try to get it, or search around for a best doc I could find? I'm in Tucson, Arizona, and it's not a really big city, so it was kind of tough. But I did a lot of investigation, and every place I checked outside the state, all around the country, they kept saying, when I said, who's the best, medical oncologist, urinary medical oncologist in Tucson for prostate cancer, who's the best doc? And I got a name, and I called him, and he got me in, and similar to you, started out immediately with the Firmagon on my first visit with him, after he had reviewed everything. But I even before that time got a second opinion, so forth, from another hospital, and everything concurred. So, but the plans change as you go through this thing. You think you got it nailed from the beginning. Okay, I'm going to go here. They're going to do this, this, and this, and but inevitably things change. And for me, the big thing to change was the doc that I was seeing in Tucson left and took a job with Mayo Clinic. So now I had further to travel than what I had initially. But I he started me on chemo almost immediately within a couple of weeks from the time that I started on the Firmagon. And that was the docetaxel chemo.
Would you help me out here, Dennis? Because all these terms are new to me. So as I mentioned, I was taking Lupron. You were taking what was initially
prescribed? Well, they gave me Firmagon was to start out with, because sometimes Lupron initially will cause what they call a tumor flare.
Yes, same thing with the bicalutamide before the Lupron. Right. Yes.
Yeah. So that mine was Firmagon. I started out on that's an injections into the abdomen, and that was not much fun either. But they quickly, several months I believe it was, and we got onto Lupron, which was a lot easier. And that's a 3-month deal there. Every 3 months I get my Lupron injections.
Let me stop you here 1 second. I have a question on Lupron.
Sure.
I've been doing some reading, and a lot of it said that people that got 30 days were fine. When some people got injections that were for longer periods of time, they had adverse physical reactions. For instance, as you mentioned, 90 days. Did you find that? In other words, did you have initially 90 days, or did you start out with 30 and then increase to 90?
No, I didn't start out with 30. They started me immediately on the 3-month interval.
Okay.
So I don't really have anything to compare it with.
Got it.
I mean, other than, you know, most of the things that they will give you to reduce your testosterone, obviously your libido, erections, and all that stuff goes away. If you get the testosterone down below detection level, that'll happen. Now, in some cases, it's probably not a permanent thing, and depending on the individual, what the treatment, you know, sometimes I get a break in treatment and so forth.
Let me stop you there. I'm 74 years old. Those heydays are kind of behind me. It's not the most important thing to me. It's secondary or tertiary.
Yeah, that's kind of the way it was for me also. And you know, it was just less important to me. The most importance was getting the PSA down and getting this cancer growth slowed down. So it worked. The docetaxel and the Lupron worked very well. It brought my PSA way down, and that worked for, let's see, about a year. And then when I was seeing another doc down here in Tucson, and he was telling me everything's going fine. In the meantime, my PSA is going up and up and up with every blood check I got, you know. So he finally told me, he says, I kept asking him questions about it. I said, shouldn't I be getting a scan? Shouldn't I be doing this, doing that? You know, he said, you don't trust me. He said, you don't trust me, find another doctor. So I said, okay. So now I went back to my old doc who'd moved up to Mayo. So you may have some changes like that depending on where you start out and so forth. We've had a number of our guys that have had some bad sessions with their docs that they at one time or another. And Rick will be the best guy to talk to from a standpoint of, you know, where to go to get, depending on where you are, who the good docs are that we've had good results with. But so I eventually got a progression. I was having a progression, and the way they found out, they did a scan, an Oxman scan up at the Mayo Clinic, and I found I'd had some new mets coming up. So I'm glad I did what I did. You know, I dumped this doc that I had down here that was ready to retire, wasn't keeping up on things. And the recommendation, they had a tumor board reviewed my situation there and came back and said, for this patient, you know, his situation here, they recommended the Zytiga with the prednisone. And now, since I got my initial diagnosis, there's been studies that have come out where they've had such good results that they're starting patients on Zytiga with the prednisone as opposed to the chemo. And my med-onc had actually told me, he said, when I went up to see him here, not 6 months or so ago, I guess it was, he said, you know, if you just came in to see me today with this same diagnosis, he says, our treatment might have been different. So I think that, you know, they're looking to see they can get about the same results with Zytiga and prednisone and Lupron as opposed to having to do chemo. Now that could.
Well, that's what I want to ask you about. I don't mean to interrupt. Right now, I'm on that trajectory of course, Lupron now, and on April 9th, they would add Zytiga and prednisone. And of course, he mentioned chemo. Have you had chemo? What's your experience? What are the side effects? What are the benefits?
I had the 18-week, I think it was every 3 weeks went in for the docetaxel infusions. And about halfway through, I guess my white blood cells had kind of gone down and my immune system was not working like it should. I must have picked up something, but long story short, I got a fever, went over 100.4, and they put me went to the ER right away, and I was having pains in my chest and didn't know what that. Every time I'd take a breath, I had big pain in my chest, and so long story short, they found multiple pulmonary embolisms in both my lungs, along with pneumonia. So after a week in the hospital, going on some daily injections of blood thinners and so forth, I was able to get out of the hospital. I had to continue the blood thinners for probably 4 or 5 months, I think, at least. But what happened didn't necessarily have to happen, because this was before they were doing Neulasta, which is the day after shot. They put me on that, and they reduced my dosage by 20%. So I continued to finish out my 18-week course of the chemo, and did okay for the rest of that time. They added the, like I said, the Neulasta shot to prevent the white blood cells from dropping too low. And it's, the chemo it's a cycle type thing. The day you get it, the day after, maybe even the third day, you're not really feeling anything yet. But for me, about the fourth or fifth day, I got really, really tired. Your taste in your mouth, things change. Don't taste good to you, and you got to watch and make sure you keep your able. I didn't get really nausea, didn't have vomiting to that extent, but a little bit of nausea.
So let me jump in.
I don't. Excuse me, one quick. I don't understand the benefits.
Larry, hold on a minute. I'll get
Okay.
back to you. We've got a lot of guys that have had chemo. I also see we've got one more new guy who's come on the call that I want to recognize. Rory, we will get to you. And we've got a lot of other guys. And my concern here is to get a very quick opinion from some of the other guys that have been on chemo, because people respond to chemo in different ways. So what I'm going to do is just quickly go around 3 or 4 guys that I know have been on chemo and have responded differently. And I'd like you, if you could, just to keep your comments down to just a couple of minutes, and just to give Larry a feel for what chemo can be like and how successful it can be. So Jim Harrington, you've been doing regular chemo. How many sessions have you done now?
Yeah, thanks, Rick. Sure, I'm happy to I'll keep it quick. 16 every 2 weeks. So, and on docetaxel, I just had one today. And yes, there's some side effects. I think that given that some really struggle with this particular drug, I do pretty well. Yes, there's what you're talking about is the nadir. You hit the nadir about 3-4 days into the thing, you get fatigue. You always have fatigue. I have some stomach pain. I have no nausea and a little bit of a headaches. And these are the typical side effects of docetaxel. But I will say on the other side is, Larry, strongly consider chemo. I'm telling you, it's my only option, and it works. It holds my PSA fairly constant. I think that eventually I'll go off docetaxel, probably onto carbo, but at the moment, it's working, and I have to have it. It's no choice, and I really think you can live with this stuff. I know a lot of men really can't stand it. They hear the word chemo, and it's anything but chemo, as Rick would say. I don't take that approach. My suggestion is, if that's indicated and you have some choices, I mean, Sandy and Saiti, these are all fine things. I've had that stuff too. I've had everything. Then don't neglect the possibility of chemo, because it does work. Yeah, you have some side effects, but I'm here to tell you 16 of these things. And so I'm a real expert on docetaxel. But Rick, I think that's all I really have to say.
Let me keep going, and we'll come back to you, Larry. So just write down any questions you've got, and then we'll come back to you. Brian Heisey, bit of a different story, but you were much younger. You were diagnosed with metastasis. Just give Larry a quick view on your situation, your Mets, and your experience with chemo and your result.
Okay, so yeah, so Larry, about a year ago this time, I was diagnosed with stage 4 prostate cancer, and again, it was similar to your situation. It was kind of a surprise. It came on pretty quickly and it advanced pretty quickly. My PSA was, I think, 16 at that time, and I had when I had the scans, the bone scans done, I had Mets all throughout my skeleton and in the pelvic area. I had some in the lymph nodes, and I was a Gleason 9 as well. Really concerned, obviously, and didn't like some of the information I was getting from the local docs. Was not happy with my urologist at all, and started doing research. Ended up at going to Mayo Clinic in Minnesota, and right away they recommended, after they did a C11 choline scan, they recommended me to go on chemotherapy immediately. Locally here in Illinois, which wasn't too far from me. So I went on docetaxel. I was also on Lupron every 3 months, and did the docetaxel for 6 treatments, 18 weeks. I had very, very good response. I think I surprised the Mayo doc a bit because he was surprised I responded so quickly to the treatments. My PSA dropped to 0.2, I think, by the time I was done with chemo.
Wow.
I ended up having some radiation done as well to treat some spots that were still showing up in the pelvic area and the prostate itself. And basically just got back from Mayo about a few weeks ago, and my PSA is now undetectable, under 0.1. So I had a lot of the side effects and went through all that. Yes, it's not the most pleasant experience. You go through a time period where you're really wiped out, but then you recover from it, and I'm satisfied that I did the right thing. And I actually asked my doc, I said, well, with the information that came out about Zytiga, are you changing course? And he said, actually, no, they're not changing course yet. They weren't satisfied enough. Chemo's been around a lot longer, and they felt that, in these kind of situations, it was the best treatment still. And once I think more is learned about Zytiga, that may become the first course. But in my case, it was chemo and it worked very well. There's a chance that I will go on Zytiga at some point, but right now I'm getting a little bit of a break. I'm still on the Lupron though. So that's kind of where I'm at. But
Thanks. And is there any, I know that there's a bunch of other guys on the call, but I'm just watching the clock here who have done chemo, different experiences, and hopefully Larry's going to come back and have a chance to talk to us and hear from some of you. But what I'm looking for on this call, I don't know there is anybody, is who else was diagnosed with metastasis, and how long ago? Is there anyone that I haven't called on who was diagnosed with metastasis and hasn't spoken up?
Yeah, me, Rick.
That's what I thought. Yeah, I thought, but I didn't have you. I'm just looking at your thing. I didn't have you as being diagnosed with Mets. Were you?
Oh yeah, I'm stage 4, Gleason 8. I've had Mets in the sacrum, the iliac wings,
Okay.
my hip, and my spine, Larry. So I'm similar to you in that respect. I don't have them in my soft tissue so far, thankfully. But I wanted to give you a word of encouragement. And everybody is different, as Rick mentioned earlier. But I was diagnosed with stage 4 in June of 2012, and
Wow.
I've been on Lupron since then, and I started Xtandi about a year ago, and so far it's keeping it in check. So the message for me is, 3 to 4 years is a lot of times too pessimistic. you may have a lot longer than you think you have.
Good to hear. Thank you.
You're welcome.
Yeah, I thought that was right, Jake, and then I pulled up your notes, but I've corrected my notes now. So Larry, let me say a few things, and then we'll let you finish off. First of all, there is a more recent movement to debulking the primary tumor. Years ago, people said, no, it just does harm, doesn't add anything, you go through additional side effects. But in the last couple of years, due to some studies that were done at Memorial Sloan Kettering and elsewhere, there is a thought that debulking the primary tumor is beneficial, and that can be done either with radiation, as 2 or 3 of our guys have done recently, or it can be done with surgery, which in your case might be appropriate to resolve the blockages. But a lot of it depends on the hospital that you're seeing. I don't know this fellow Roma. What did you say his name was? Roma Lugan?
Ramalingam.
Ramalingam. So I don't know Ramalingam. My go-to guy, our go-to guy at Duke has always been Dan George, who is phenomenal, absolutely phenomenal. We've known him now treating several of our guys for probably 5 years or more, including a guy, sadly, that we lost a couple of years ago, who's really one of the patron saints of this call. And he's a very good, compassionate doctor. The problem, of course, is that once you're in with somebody in a place like Duke, it's kind of hard to switch. And if this guy Romalingen is one of the younger guys there, he's probably working with and under Dan George. And as long as he's a GU med onc and he's in the genitourinary group, oncology group at Duke, you're probably getting decent treatment. And he's making, from what you're telling me, the sort of decisions he's offering you sounds correct. I'm going to send you a conversation that you can listen to. It's a sort of a webinar between Alicia Morgans, who's at Northwestern, Chris Sweeney, who is at Dana-Farber, and Chuck Ryan, who has been at UCSF for many years, was the principal investigator for Zytiga, and is about to move to University of Minnesota in a couple of weeks. And they discuss sequencing treatments. Do you do chemo first? Do you do one of the secondary anti-androgens like Zytiga or Xtandi first? Do you do them both together? Yes. And it's a very good conversation. What I would say to you is that the tests, the clinical trials, show a lot more benefit to chemo right now than they do to Xtandi and Zytiga. Although the most recent tests from Zytiga seem to suggest, when used earlier, it can give close to what chemo can do. But in the past, chemo has really given you the biggest bang for your buck. And listening to this recording will certainly help you a lot. I'm also going to send you a hormone therapy pamphlet, which is going to tell you a lot about being on hormone therapy, which I doubt the doctors have told you because they rarely have time, and they rarely do. And we don't have time to get into that. But again, as long as you come back to us, you will be you'll start to become pretty well informed. There was one other thing that just went through my mind that I wanted to mention to you. I forget what it was. If you want to put your email in the chat box, I will add you to the group, and so you'll get a weekly notice, and we can go from there. But you do it. Oh, I know what I was going to say to you. You asked about the 90-day shot. Most of us have done 90-day shots on the call. There are a few guys that opt for 30-day shots, but I don't think that there's no difference in terms of the side effects that the hormone therapy causes. There may be a little bit of difference in terms of the topical soreness, because the 90-day shot is bigger than the 30-day shot, so it's going to be sore for a little bit longer. But you're not going to have any different side effects, and the side effects are cumulative. So the longer you're on the hormone therapy, the worse it tends to get. But there's a lot that we can do to help you in wrestling with those side effects. Sadly, in your case, you'll probably never come off the hormone therapy, and we've got guys on this call who are in that situation. And again, we can work with you, and we can help you. So let me go back to you, because you may have a few things that you'd like to close with.
First of all, I appreciate everybody sharing. I don't want to say encouraged. I am still reeling from the diagnosis and all the changes in my life in the last 20 to 30 days. I think when I say the correct direction, because nothing is off the table at the moment, but it seems if I'm on, I was on bicalutamide, now I'm on Lupron. I will be going on the Zytiga and prednisone, that I will then see what the results are at that point, 60, 90 days down the road. If they don't take hold and reduce the metastasis, etc., then I might consider a chemo. I am not saying it's off the table, but it's something that I look at a progression as opposed to going there first. I don't know if that's correct or not.
Mm-hmm. No, I mean, I think it's certainly one way to go, and like I say, I think I think you'll get a lot out of the conversation that I'm going to send you. But be sure to, or let me also give you my email address. I think it was on the notice, but it's RD.
RD, yes.
Hold on a minute. It's RD as in Rick Davis at
right.
ANCAN. That's A is in Alpha, N is in Nelson, C is in Charlie, A is in Alpha, N is in Nelson. ANCAN.org, O-R-G. So if you send me your email or put it in the chat window, what have you, I'll get a whole bunch of information back to you. And I just want to tell you a little bit about our groups. This group meets every week, either on a Monday or a Tuesday. Monday at 8 o'clock, Tuesday at 6 o'clock Eastern Time. We have two other groups that might be of help to you and your wife. We have a Caregivers group, which is meets twice a month. Our next meeting will be tomorrow at 6 o'clock Eastern, and you join it exactly the way you join this meeting. And then we have another group called the Inner Conversations group, which Jake and another gentleman co-moderate. And that group really supports you on a more emotional level. In other words, they're really talking to you about how you're in a tizzy right now, how this has disturbed your whole life and thrown you off kilter, and what their other people's experience has been, and how to center yourself. And so they're not really talking about treatment. No one on the call is a therapist. These are all guys that have experience. Several other guys on this call will be on that call. And that meets on Wednesday also at 8 o'clock Eastern Time. Right, Jake? 8 o'clock Eastern Time.
That's correct. And that's every week, Larry.
That's every
Wednesday at 8 o'clock.
So let me put it this way. I plan on being all of these initially, and then I will have to make some decisions as to what I feel is most relevant and et cetera that meets my schedule.
That's fine. You know, you can
Okay.
come on, but the one tomorrow is for caregivers. So your wife, that's the one for your wife, not for you. Okay? Because we'll take care of you on this call and on Wednesday, but the one tomorrow is your poor wife who's also reeling, and we try and give her a little bit of support.
Yes, that's appreciated.
Okay?
Rick, let me just, I want to, the email.
Yes.
R is in Robert, D is in David at ANCAN, ANCAN.org.
That's right.
I will get that out. I will get an email out to you, just a cover email with my diagnosis sometime this evening.
Okay, and then we'll send you some back, and there's a lot of information on our website, which is ancan.org, and we'll start working with you, and hopefully we can make this journey. It's a rough journey, but our job is to make it as smooth as it possibly can be. And I think you'll listen as you listen to some of the other guys now. You'll hear that we've had some success in doing that. That's what we're here for.
Well, again, I want to thank everybody for sharing everything, and I'm a little bit more positive now at the end of the call than I was at the beginning of the call.
Great.
And that's a good thing.
That's what we aim to do. Rory Hagar. Rory, I don't think you've been with us before. Is this just the first time you're calling? Hello? Ah, I can see a yes, but I don't hear you. Does that mean that your microphone is not working? So if your mic isn't working, Rory just sent me a note that said yes. But if your mic, yes, the mic's malfunctioning. Well, if your mic was functioning, we would love to talk to you and go through just like we did with Larry. And we hope that you can get your mic functioning. Come back and join us again. The next meeting will be on Monday, the 26th at 8 o'clock.
Tuesday.
Wait a minute. Today's Monday. Tuesday. Thank you. Tuesday, the 27th at 6 o'clock Eastern, or wherever you are. Tuesday, the 27th at 6 o'clock Eastern. Sylvester, you're not the only one who's calendar challenged. And so yeah, come on back, try and get that mic working, or call in, because you can call in, and if you call in on the phone, or if you come back in a few minutes on the phone, and we can work you in. But it's already 10:02 and we've got a lot of guys, so it might be better, if it's not inconvenient for you, to come back on Monday, and we'll put you first up, and you can tell us about your situation. But right now, I'm going to move down the list and see who would like some time tonight. Sylvester, anything for you tonight?
No, thank you very much.
Okay, Jake, how about you?
Nothing tonight, Rick. Thanks.
Okay, Peter, Kafka.
I could give a quick 2-minute report on the germline webinar I just attended just before this meeting.
Okay.
It was excellent.
Okay. Brian Heisey, anything for you tonight?
Nothing tonight. Thank you, Rick.
Okay. David Sibley, you want to give us an update?
Well, I can do that, but there really is no update yet. So I'll just listen in.
Okay. Does that mean you haven't started doing anything yet?
I haven't started the trials. I go for my final testing and getting a port installed this week.
Okay. So if we have time, we'll circle back to you, just because it would be interesting for somebody like Larry to hear about what this trial is. But we will, let's see how we do with time. Dennis, anything for you?
No, not tonight, Rick.
Eric, how about you?
I could give an update.
Okay. Jay Curran, anything for you?
Yeah, a quick update and a couple questions.
Okay. Jay Kruckman, anything for you?
Nothing tonight, Rick. Thank you.
Okay. Gigi and Dan, welcome. Delighted to see you on the call. Whether you want it or not, we're getting an update. Is that okay? Are they still with us? Oh, yes.
Is that Dan Roden?
Yes.
Yeah, he's showing muted. He sent a message out. He was trying to get on or trying to talk, but he couldn't do it.
Here now?
Oh, I can hear you, G.
Oh, there he is.
Are you there?
Yeah, we're here.
Okay, we're coming to you. We'll get a quick update from you, please. It's lovely to hear your voice.
Okay.
Paul Frieder, anything for you?
Nothing for me tonight, thanks.
Okay, Gary, anything for you?
Just listening tonight.
Good, good. Shref, anything for you?
Yeah, I might give an update, be useful to Larry.
Absolutely. Jim Harrington, anything for you?
No, not tonight, Rick. I'll just listen.
Okay, John Appler, for you?
Rick, thank you very much for you and Peter both for your help over the weekend. I'm fine tonight. Thank you.
Good, good. Bill Franklin, anything for you?
No, I'm just listening, Rick.
Okay, is there anybody that I missed, that I didn't ask?
You did a pretty good job. I think you got them all.
Thanks, Jake. Thanks. I need a cheerleader tonight. Okay. Peter, I'm going to defer the update on the gene seminar and see how much time we have at the end, if that's okay.
Of course.
Okay. David Sibley, I will also come back to you, and so we can talk just a little bit about that if we've got some time. Eric, tell us how you're doing.
Well, I don't remember where I left off, but I had 2 PSAs that went down, and then the next one went way up. So it's at 28.5 now. So I talked to the Geonc at UCSF. Well, I texted him, and he said he wants me to. I just had a treatment on Thursday. He wants me to have one more treatment, and then we'll do a scan after that, and we'll make decisions based on what that scan shows. He was asking, he wanted a bone scan, so I guess that's what we'll do. Overall, my health has been okay. I still have a low blood pressure problem. I went in today and got hydrated, and that helped some. I have a meeting on Thursday with several doctors at in Berkeley, and maybe we'll make some evaluations then, but I'm really waiting for my next conversation with Dr. Agarwal to figure out where I'm going. So I was discouraging to get that PSA going way up after it got down.
Right, but it's been. We should just let people know on the call that Eric's been doing a combination of carboplatin and Jevtana.
It's reality.
And so the plan now is to do another carbo and Jevtana this week, and then to get a bunch of scans at UCSF. Is that right?
Not this week. It'll be done in 3 weeks altogether since last Thursday. So 2 weeks from this Thursday.
Okay. And what is the objective of the meeting on Thursday with the Outer Bates folks?
It's just a long scheduled meeting. You know, was scheduled in January. So
okay.
It doesn't have a particular purpose except going over my current status.
Okay. Okay. Are they are they talking to Agarwal? Are they sharing notes along the way? And
Yes, they are.
okay, okay.
Yeah, and the new doctor, was very much in favor of going along with the UC doctors, and she was sending him a note as some status, and they do seem to communicate fairly well.
So this is Dr. Uma with the last name that we can't pronounce, correct?
Yes.
Okay. Now,
Saria Devara.
thank you very much. You're getting good at that, Eric. Let me just say, and I'm looking at something here because it is sort of, it's interesting that you get a little disheartened by the PSA, but basically the PSA is swinging in a range between about 15 and 30, correct? Since the beginning of the year.
Yep.
So, it goes up, it gets up close to 30, it comes back down close to 15, it goes back up to 30, but it is sort of sticking in that range pretty much, huh?
Yes.
So,
they'll do another PSA on Thursday.
Right. And at least you finally have a solution to the BP in staying hydrated. I mean, that's positive too. And you still don't need to be on the opioids. You're still managing without the opioids.
No, I had to go back. I take 1 15 milligram MS-Statin in the morning.
Okay.
I was getting pain in my back, so I had to go back.
Okay. Okay. Well, I guess it's going to be interesting to see what happens in your next meeting with. I mean, that's going to be the key meeting, the next meeting with Agarwal, right?
Right. Yes.
So, there's not a lot that we can say. Anybody want to say? Anybody like to talk to Eric? Yes, not.
Jay Kern.
Yes, go ahead, Jay.
As I recall, you had to go to the hospital as an emergency situation, and did that turn out to be from dehydration also, do you think?
Well, it was the same solution. They hydrated me. The first time I went, they did all kinds of tests trying to find out what was going wrong. They couldn't figure anything out, and they gave me some steroids to increase my blood pressure, and then the endocrinologist gave me a different steroid, and Berkeley people gave me another. So I have 3 that I'm on. I'm not quite sure why I need 3 different ones, but so 3 different steroids that are supposed to increase my blood pressure. I still, sort of a set number, 4 or 5 days after I get the transfusion, it starts, and it keeps going for a week. And if I do get hydrated, usually it brings the blood pressure up. I had 1 liter today, and the blood pressure actually was still relatively low, but I didn't hang around for another liter. But I'm going in Thursday. I'm already scheduled for another hydration after I see the doctors. So, it does make a difference. When I get hydrated, it makes me feel a lot better. And it doesn't seem to help no matter how much I drink. I just don't absorb it. So, getting it IV is seems to be all it's going to work.
And this is saline, correct, that they're giving you?
Yes, normal saline.
Normal saline. And there's no shortage in San Francisco? Because we keep hearing about this shortage of saline.
Yeah, they said it was because the factories were in Puerto Rico.
Yep, exactly.
And so there was a shortage. But no, they haven't expressed that to me. I brought it up one time, but they said that they were getting what they needed.
Okay. How's that hair doing? I still see we got hair.
A little bit left.
Looks good.
Not much.
It looks good. It looks good, man. All right, well.
Hey, Eric.
Yeah.
Rick, I just wanted to ask Eric, and forgive me if I already asked you this, but it's been on my mind. I know you had a very bad reaction to your first chemo go-around with docetaxel, and yet here you are now taking 2 chemos simultaneously, and you seem to be tolerating it amazingly well. Did you ever ask the doctors how that's possible, or why it is that you're suddenly tolerating chemo so well, whereas before you didn't?
Well, I think that the docetaxel just, affected me more than the current cabazitaxel. And, I don't think it's my health that's any different. I lost, 30 pounds on the docetaxel, and I've lost 10 now on the Jefferson cabazitaxel. I don't have any further explanation. One other odd thing was that they had me on prednisone when I was taking the docetaxel. I took prednisone every day, and I'm not taking neither that nor Decadron. They took me off both of those, and I've stayed off, and I do okay. I said all along, though. Go ahead.
Eric, this is Jake. Didn't you just say that you're on 3 different steroids?
Well, they're different. They don't act like Decadron or prednisone. So,
do all 3?
That is the reason that they didn't put me on prednisone, because I was already taking all those other steroids.
Okay.
But,
so all the doctors who've given you those 3 different steroids know that you're on all 3 at the same time?
Oh, yeah.
Okay.
Yeah, every time we go in, the first thing we do is review meds. And I have my own full page typed up, in the computer, and I print it out before I go, list of all the meds I'm currently on, prescription, non-prescription, and then I also have a list of meds that I used to take and I'm no longer on. So they do review that as well when they're considering a new medication.
Eric, did they ever comment, we talked, I remember a few weeks ago, about possibly the steroids having an impact on your low blood pressure, and you were going to talk to them about that. Was there ever any comment on that, or was there any association with the steroids driving down your blood pressure, the prednisone and the dexamethasone?
Yes. Yeah, they definitely said that, I have Addison's disease now, and that was brought on by being on the Decadron for too long. And, who knows
you
if
and
that will
JFK.
start reverse.
Yeah.
Pardon me?
You and JFK, that's what he had.
Yeah.
Addison's disease, is that a thyroid condition?
Adrenal gland insufficiency.
Adrenal gland not working.
Right, I knew it was one of the glands. Okay.
And
you watching that? Sorry, go ahead, Eric.
I was just going to say it's a known phenomenon that if the steroids will cause the adrenal gland to quit working, and sometimes it doesn't start up again when you quit, which seems to be my problem.
And that can be a cause of driving down your blood pressure?
Yes.
Okay. Yeah. You heard it on this call first.
First.
So, well, we told him.
Jake.
We said to him, go ask your docs about, there seems to be some correlation between these steroids and your blood pressure. So,
I just wanted to ask Jake, are you watching that CNN special on the Kennedys?
Yes, that's how I knew the JFK had Addison's disease.
Yeah. That's a fascinating series.
It is very good series.
And I want to say I'm proud of you for watching CNN.
Well,
I won't tell anybody that you did.
Our lips are sealed, Jake. We won't.
Okay, Deanna, please don't tell anybody. My reputation will be ruined.
Absolutely.
Yes.
So, all right, we'll move along. But you know, you're looking pretty good there. You're looking a lot better than we've seen in the past. So thank God for that. And good luck on Thursday. And hopefully we'll get some good news. And hopefully what we'll see in these scans is a further reduction in the tumors, Eric.
We can hope.
Okay.
Good luck, Eric.
Gigi and Dan, we haven't heard from you for a long time, and I hope you're just going to give us a positive update. I hope. Tell us what's going on. Just fill the guys in a little bit about your situation, and because I know, but they may not know, and tell us where you are.
Okay. Go ahead.
Okay. This is Dan Roten. I was at UCSF. That's where I got treated for a radiation treatment back last summer.
Yeah. I'm going to jump in.
Gigi can speak much better than me.
Dan's a Gleason 9, and we're coming up in May on his 1 year from the start of treatment, and he had and is due to have 2 years of ADT, and he had 25, the triple treatment, 25 pelvic radiation treatments and 1 HDR brachytherapy. And his PSA, his two,
Lupron.
And he's on the Lupron. So a 6-month Lupron shot, by the way, which he's not too happy about, but his undetectable PSA, so that's good.
The last time I got it checked.
I have to.
Pardon?
Can I interrupt for a second? You said you're not happy with 6-month Lupron. Can you fill me in on that?
The reason I'm not happy with it is because of the side effects, which I'm getting a lot of night sweats or hot flashes or heat, and it's very disturbing. And I don't know if it's a 6-month or if it's just, I got them on all. I had 1 month to start with, and a 3-month, and then a 6 months.
So let me just jump in and then we'll come back to you. It doesn't have anything to do, Larry, with the size of the shot. It has to do with the cumulative effect of the hormone therapy. So you could have had 12 1-month shots, and if you were Dan, you'd still finish up with the hot sweats and everything else, because that's how he responds to a lack of testosterone in his body. The problem with that 6-month shot is that it's a big shot, and it takes probably a week for the swelling around the shot to go down, as opposed to maybe half a day if you have a 1-month shot. So that's really, I don't want you to think that a smaller shot is not gonna have the same impact over time as a large shot in terms of the side effects. It has exactly the same impact because it's
understand
testosterone.
Yes.
Okay.
Rick, comment. I don't know if that's true about the swelling. I'm on the 4-month Lupron shot, and I get it in the meaty part of my shoulder, and it doesn't swell. It's sore for about a day, maybe at the most. If you remember in high school, kids would punch you in the arm, and it would just hurt for a while.
Yeah.
And that's so I don't know. Like Rick says, the size of the shot really makes no difference, but it doesn't really cause any swelling in my case.
Right. Well, I mean, that's a great suggestion, Jake, is to consider, maybe getting it in a different spot. I mean, I know I got all my shots in my buttock, and they were sore for several days.
Yeah. I was never given any option except for in my buttocks, as Rick say.
She never gave me an option either. She just gives it to me in my arm.
Hey Dan, I wanted to say that when I was on Lupron, between 6 months and a year were what I felt was pretty much the worst symptoms of night sweats. I had horrible night sweats.
Yeah,
and hot flashes during the day. After the 1 year mark, as my testosterone got to pretty much basically zero, those kind of alleviated. I always had hot flashes or night sweats, but maybe like once a night. And they got to be it got to be manageable actually as I went through the whole 24 months. So, and you probably weren't on the call a few months ago when I said that when I came off it, as my testosterone started going back up, I started getting hot flashes again. But those have since, those have leveled out too. I'm not really getting them anymore. So.
Oh, thank you.
But just, that was my experience between 6 months and probably 14 months was probably for me the worst time on the Lupron. And I kept a pretty precise log of, every night I wrote down how many times I got up to go to the bathroom, how many night sweats I had, so I have a list of everything that happened. So I know which months were good and which months were bad. So.
Thanks, Bill. That's
good.
Impressive.
Dan, who is your radiation oncologist, if I can ask?
Mac Roach.
Roach, okay.
CSF.
At UCSF.
I know.
Right. So keep going and tell us more, and then we'll come back and talk a little bit about these night sweats and a couple of other things. But we interrupted you, so you have the floor back.
Okay. Well, Gigi can speak.
Well, we're sharing a brain and a tongue and everything now.
Okay. She's better at speaking than me.
The Lupron shot business can kind of lead into, we're really here to listen, but specifically when Dan sees the doctor again in May.
Yeah, I'm going out there in May.
So we'll be hitting 12 months on the Lupron.
13.
And 13. And the question about the 24-month program, and now 18 months is looking like standard care.
Right.
So we want to bring that up with him.
Very good.
And when Dan first went, and we mentioned the length of the Lupron, because he wanted to do it longer initially.
3 years.
And then we, Dan sort of stuttered and then he went to the 2 year. So we're wondering
can we cut down?
About what kind of pushback and how to deal with him in case he wants to go the 24.
Right.
Dan would like to do the 18.
Trying to get off the drugs.
And also, just another thing is worried about the Lupron creating castrate resistance. The longer we go past a year, I don't know. And should we worry about that?
So let me hit a couple of those things. Probably nobody in this country is better educated on all of the studies on how long to stay on Lupron than Mac. It's kind of his sweet spot. So he knows very well the study that came out, I think it was a year or a year and a half ago, whenever it was, 2 years ago, that says 18 months is as good as 36 months. And let me just add one thing for those listening, for people like Larry Burke. The reason we're talking about a definitive time for the hormone therapy is because this treatment, this hormone therapy treatment, is initial treatment. Dan, thank God, did not have metastasized disease, and his disease hasn't come back. So this is part of the primary treatment, and that's a different situation to what a lot of you guys on this call are wrestling with. It is the same situation that I had to deal with, so I'm sort of familiar with it, where I had a high-risk, high Gleason diagnosis, and as some of you know, Mac Roach was also my doctor, so I can speak to Mac's responses quite well here. When I was doing my treatment, and I know you've heard this before, Gigi and Dan, when I was doing my treatment, a study came out that said that 36 months was better than, I think it was 6 months or 12 months, I forget which. And I wrote Mac a note, and I said, should I stay on this then for 36 months? And I was having significant side effects. And he wrote back and he said, we really don't know. We don't know what the right time is. He put me on for 28 months because at that time there was another study that said 28 months was better than 4 months. So my own gut feeling on this, if it were me now, is that I probably would feel comfortable with a minimum of 18 months. Do I need to go beyond 18 months? Not really sure. Am I worried that it would cause castrate resistance more quickly? God forbid it doesn't cure me. I don't think that bothers me as to the length of time. But I do know that I wouldn't want to get off before 18 months. And how much longer I stayed on after that is really, how well I can tolerate it and between my doctor and I. But I think it's a very, very viable conversation to have with Mac as to whether, if 18 months is as good as 36 months, do we really need to stay on longer than 18 months? And as you know, there are a bunch of docs now that are talking 12 months, 18 months, what have you. My personal observations, purely anecdotal, is that guys that have gotten off the hormone therapy too quickly, when it's been offered as initial treatment, have had more problems later on and the disease has tended to come back. Doesn't mean to say you stay on longer, it won't come back, but I just have seen more success, and I'm an example of that, thank God. So, I think it's a very, very viable discussion. I don't even think you need to, Gigi, I don't think you even need to print the studies out because Mac's going to know them back to front anyway. And, it's but I think it's a very viable discussion. Secondly, the night sweats. The one thing I would really recommend, and I know we've talked about it before, if you haven't tried it, is I would try acupuncture, because a lot of more and more guys I talk to seem to get relief from acupuncture. The problem with the acupuncture is that it's only 3 months. It's like a 3 week, and then you have to go in for 3 weeks later. But some guys are getting a lot of relief from it, and the acupuncturists know the points because they treat women for menopause in the same points. And people have had success. I don't. Anybody on this call tried acupuncture for hot sweats? We do have guys, and I could look it up afterwards. But I would really encourage you. I mean, there are drugs you can take. Megace is one, but there's some downside. Depo-Provera is another one. There's some downside to that. But if it's really bothering you, again, anybody on this call ever used any drugs for their hot sweats?
Rick, I haven't used acupuncture, but several members of my local prostate cancer support group up in Connecticut have tried that for hot sweats, and they said it was remarkably effective.
Right. Yeah. And
we'll try that. Thank you. That's a great suggestion.
Yeah.
But his hot sweats all day, but at night it's created a problem with both of our sleep. It's unbelievable.
Right.
Sleep deprived zombies.
Well, look, try.
We'll try it.
Try the acupuncture and let me know in a couple of weeks how you do with it.
Will.
See if you get a response. And if not, there are some other things that we can talk about. But try that first of all, because it's not there's no drugs involved. It's not particularly invasive. I hope you don't have a problem with needles, Dan. I know you don't have a problem with electric saws. Have you been chopping any fingers off recently?
Well, I cut my hand.
I know.
Yeah, he knows.
And I've been dealing with that.
I know. How's that healing?
It's healing. It looks okay, sort of looks okay. I mean, everybody thinks it looks okay. I don't, but
Yeah. Well, for those on the call,
on the table saw, and it's doing very well.
it's doing well. I've got a couple more weeks of therapy and physical therapy and mental therapy because I feel like I've got like a post-traumatic stress thing going on.
Oh man! For those of you who and you don't know, but Dan works as an artisan boat builder in Newport, Rhode Island, on wooden boats, on wooden ships, on wooden boats. So it's kind of difficult to do that job when you're missing digits, but no digits are missing. But we came close, correct?
Exactly. They were considered amputated almost. They were broken.
Yeah.
And my index finger, my left hand was laying back.
Oh man.
Anyway, it was really.
It was a distraction from the prostate. So now can you see that?
Yeah. I'm just thinking with that index finger, it might be a problem if it happened to a prostate cancer doctor as well.
Well,
Or it might help him.
Or it might help. Yeah, that's right. Could leave his finger up there. That would be terrible. Look, how's your mental state?
Well, I feel kind of lightheaded, fuzzy-headed a lot.
Mm.
And I'm wondering about going back to work, but I'm still going back to work as quickly as I can.
Mm-hmm.
And that affects my mental state and just doing things. I'm having a lot of trouble doing anything, really.
We're wondering if the Lupron isn't creating a lot of mental fuzziness. And,
it is. It is.
It is, yeah. And dizziness and
yeah.
He drives sometimes a little funny and
have you
bumps into people.
Have you are you getting sort of regular checks? I mean, are you checking your blood pressure? And because the Lupron can, especially after 12 months, start to impact some of your metabolic issues like your sugar, your glucose levels. I mean, yeah. I have known other people that have gotten lightheaded because their blood pressure has changed. So, I mean, these are things that probably it would be a good idea to, check in with a local doctor and just get a physical and make sure that even before you go see Mac, because there might be issues you want to talk about with Mac.
Right.
Well, one thing I've had.
Your blood work's good.
My blood work is good. I had a hernia.
Oh yeah, he came down with a inguinal hernia just about a month ago, and we're going to see a surgeon tomorrow
morning.
Just a first look-see.
Right.
And that was another question.
I had an ultrasound.
Right.
So
do we have any hernia survivors on this call? There are plenty of them. Anybody had a hernia on this call?
Larry Burke, the answer is yes.
Yes.
Several times.
Well, one thing we were wondering about the hernia, sorry, I'll make it quick, but was whether first of all, whether there's a problem with having such radiation treatment in the surgery to fix it. Whether the radiation, if there's a reason to wait for it, or is there healing that's being done?
Mm-hmm. Good question.
And,
or is a hernia caused by the radiation?
Well, it's there, so.
So let me just answer that quickly, and then I want to go to Jay and whoever else it was that said that they'd had hernia treatment. It could be because the certainly hernias arise quite frequently after radical prostatectomies because of the injury that's done to the body from such a significant operation. So we do see guys getting them. As far as radiation is concerned, the radiation does affect the muscles, and can it weaken them? You know, I guess it can. I don't know enough. Again, Mac would be the best person, and you should write to Mac. I would encourage you to write to Mac and ask him that question, and ask him about surgery pursuant to pelvic radiation, because
For sure.
he is the guy that will have that answer. I will tell you, I just got a new hip, and the doctor said to me that it's quite likely that because I had so much radiation to my pelvic area that it could have compromised the damage in my hip. So radiation is invasive, and it can damage. J Bob, do you want to do you want to say something about the hernia?
Well, I had 4 hernias repaired. They were guano, and they came in with 2 incisions. And so far, so good, but I am picking up a little pain. I'm going to see my surgeon in a couple of days.
How recently?
That was in June of 2017.
Okay. And was that after radiation? I don't have your record in front of me. I can't remember.
No, all I was on was Lupron and Firmagon.
Oh, right. Okay. And anybody else? Who was the other person that said they had hernias?
Larry Burke. I had them, but they were so long ago they're not associated with this.
Okay.
In other words, they were in the mid-late 70s.
Oh, okay. Anybody got any advice for or suggestions as to what Dan should be talking to the surgeon about when he goes in tomorrow?
Dan, this doesn't relate to the surgery, but I strongly suggest you look at saw stop safety devices for table saws. They're really good.
Yeah, that's a little bit worrisome. Saws.
Where I used to work, they bought one recently, and it's well worth the price.
They've replaced the saw that I cut my hand on with one of those saws.
Right away.
Right away.
Good.
Yeah, we were. Yeah.
Okay.
Dan, this is Jake. I have a couple of suggestions that might help with your fogginess. And we've talked about this before. You know, a lot of people find doing something mental exercises helps. Like Rick likes to do puzzles. I like to do crossword puzzles. And they help me just kind of focus, keep me a little bit sharp. And as for the dizziness, I found that if I feel lightheaded, and I do relatively frequently, I take an antihistamine, like an allergy pill, and that seems to knock it out. You have to be careful. You don't want to be using the table saw when you're on an antihistamine, or driving maybe necessarily, but they do help.
Okay. Thank you. That'd be good. That's good enough.
It's worth a shot. It's over the counter.
Mm-hmm.
Yeah.
Like Benadryl or something.
Anything else for Gigi and Dan before we move on?
That's good.
Thank you, everyone.
Thanks.
It's our pleasure. It's good to hear your voice. I'm glad that you're retaining all your digits since we last spoke. And and we'll talk again soon. And I really hope some of the tips that we gave you today will it just improve your quality of life and make it a little easier for you. But
peace of mind. Thank you. Yes.
Peace of mind. But hang in, and Gigi, come on the old caregivers call. You can
I will for sure.
Joke around with us. And Dan, I tell you, I think you have been on Jake's call, but
yes.
There's a lot of laughs on that call, I will tell you. I mean, they absolutely cracked me up last week. Fortunately, I don't moderate that call because I'm not sure I could keep a straight face for long enough. But there's some serious.
Well, that's why we have such a good time, because you're not moderating it.
Exactly right. That's right. But it is
You're welcome to join us every Wednesday, 8 o'clock Eastern time.
Okay.
Thank you very much. We'll do that.
Okay.
All right, Rick.
Pleasure. Jay Curran, you have the floor.
Let's see. My PSA was doubling every month for about 4 months and went up to 101. That went down to 54 within about 2 weeks when I went on Zytiga and prednisone. Now it's down to 12. And so I'm happy about that. But I don't know if I mentioned this before, but I had a little problem with sort of weeping from the end of my penis. I'm wondering if the prednisone makes the skin thinner. And I'll be seeing my nurse practitioner about it in 3 days, but I just wondered if anybody else had any experience like that.
I haven't heard that one, but is there anybody on the call that has any thoughts on that or suggestions?
I haven't heard of that either, and I have heard that topical steroids, chronic application of topical steroids can thin your skin, but not a systemic steroid. And the prednisone you get with Zytiga is a low dose, so it's unlikely to be the cause.
Okay. And I'll be seeing Dr. Agawel on I think it's May 6th or something like that. Has anyone had much experience with him or?
Eric, are you still with us? We have to wait for him to unmute. I can't remember. I'm not sure. Is he still with us or not?
I think he dropped off, Rick.
Yeah, he dropped off. So, so Eric clearly has. Eric came to Agawal because we finally got him to go to UCSF and look for clinical trials. This must have been about 2 or 3 years ago. And so he started working with Agawal and he stuck with Agawal. I know Rahul. He's a really good guy. He has a very nice manner. He's youngish. I guess he's probably somewhere between late 30s and mid 40s. It would be my guess. He's very bright. I think he's on top of his game. So I'm not sure what else I can tell you. I would not have a hesitation in referring to him. He probably would not be, for me personally, wouldn't be my first choice. But I don't think there's anything untoward. Dan Louie, who hasn't been on this call for a while, I wanted to line him up with a different doc, and he saw Agawal and they really like him, and he's been with him all along the way. So I don't have anything bad and really only positive things to say about him. I don't think there's anyone else on the call who has experience with Agawal.
I understand he does take a little bit of time with you. He'll spend some time with you. That's my
I wouldn't be surprised because he's a caring guy. He doesn't sort of rush you in, and he's not sort of always in a rush. So I can see that he wouldn't rush you in and rush you out. Having said that, I don't know because I've never sat in an appointment with Agawal. Eric would be, Eric would tell you, but I think Eric likes him. I do think Eric likes him, so I can't tell you, I can't say more than that.
Thank you.
Okay. Scott, Shreff, you're up.
Oh, thanks. Hey, couple things. Wanted to give Larry some encouragement. I got
bring it on.
He's gone?
No, I said bring it on. Encouragement.
Okay. My diagnosis came in October. Still going through the same anxiety and anger and all the emotions. They put me on Lupron and Ditiga, and my PSA went from 23 to, I guess the last test was 0.03.
Wow.
So there must be working. Prayer helps a lot as well. So just hang in there. It'll. And this group's been a godsend for me.
Scott, thanks. Thank you.
Oh, and then about the hot flashes, I go to another doctor for alternative treatment. She's an MD, and she referred me, or it's not a prescription, but it's called Rebel Herbs, and she uses a lot for menopausal women, and asked me to give it a try, and it seems to help. Take a few puffs off of it. It's an e-cigarette. It's a blend of CO2 extracted oils of flaxseed, Cholestris penicillata fruit, turmeric, rhizomes, Bacopa monnier, pandanus flowers, peppermint oil, and spearmint oil. And it seems to take some of the rush off of the hot flashes. I get them all night, all day. I don't know. I think probably the lowest number's 14 or so a day.
What was the name? What was the name of the compound again?
Rebel.
Rebel.
Yeah, Rebel Herbs.
Yep.
Okay.
Oils.
Rebel Herbs. So there's another one for you, Gigi. Go get them. The only thing I would say, we always say this, is if you are going to use a compound like that, make sure that your cancer doctor is aware what you're smoking, what you're taking, smoking, vaping, whatever, however you're doing it. I'm all for complementary medicine. I really am a big believer that it can make a difference. But we feel quite strongly in this group and in Answer Cancer that you must keep your doctors informed if you are using herbs and supplements outside of your of what they're prescribing. Have you tried acupuncture, Shref?
Not for hot flashes.
You might want to just discuss it with your complementary medicine lady and see what she thinks about that. See what she has to say about it too.
I think she offered it to me.
Okay. Do you have any any other side effects that we can help you with?
Fatigue and lack of brain power. I'm going to make an appointment with a endocrinologist at the clinic.
I think that's a good move. The fatigue again. Have you, or where are you in terms of incorporating an exercise regime?
I got the Man Plan package.
Oh, good.
Yeah, you guys recommended that, but I haven't used it yet.
Okay. So you're not exercising yet?
No.
Okay. Well, I do think that when you start to exercise, it's going to make a difference. It's going to make a difference in terms of your fatigue. It's going to make a difference in terms of your mental acuity. And so I would definitely try and incorporate it, but the Man Plan alone isn't going to solve the aerobic part of it, which you do need to incorporate. So, maybe along with those rubber bands, you need to go onto Craigslist and get yourself a used exercise bike or elliptical machine or something like that. It's going to. will anybody on this call testify as to the difference exercise has made in terms of their fatigue and mental outlook?
Well, Rick, it's Jim
Enormous
Harrington.
difference.
Yeah, it's Jim Harrington. I absolutely, exercise is key. You know, I always say this, and I'm known to say this all the time. And sometimes you just, for the fatigue part, you just got to get off the sofa and off the rest and just go exercise, do something. I have my own weights and a weight machine and so forth in my basement, but it makes it very easier. Walk or do something, and it really helps. I think that exercise is just known that it really is very helpful in cancer. And I find, because I'm on chemo and I've had lots of chemo and still have it, and I get fatigue, and it can help.
Yeah, I second that. Halfway through my ADT treatment, I took up karate at the place where my kids were doing it, and it made a world of difference. I was already swimming a little, walking a lot, but the karate, the workouts were much more intense. They were taking me, past that point of the aerobics and the physical, the weight bearing exercise. So it made a world of difference.
Thanks, Bill. Now you have two half children, right? You've chopped them right down the middle.
Yeah. Well, they're half Japanese, half Americans. I do
go.
call them halfies sometimes, but I don't know if that's politically correct.
All right, we won't say anything. We won't tell you why. Len, you wanted to say something.
Oh, yeah, just seconding or thirding what the others have said. Shref, exercise may sound counterintuitive, but you go out and you exert yourself and you're physically, and you'll actually feel less fatigue. Maybe not immediately, but soon after you start a routine, you'll feel better. You'll see your muscle tone, if not getting better, certainly not getting any worse. And I was alarmed the first few months I was on ADT, and then I met Rick and Dominic, and they both urged me to start exercising, and it made an enormous difference. And of course, it's not just in cancer, but for any field, they'll tell you that exercise is great as an antidepressant.
Yeah. So, and Shref, the other, are you you're semi-retired, right?
Working on it. Yep.
Oh, you're working, and as I recall, you practice law.
Correct.
And you're still practicing. You haven't gotten it perfect yet.
Yeah.
Not even close.
And you're ready to retire. You're still practicing. When are you going to get there? What kind of law? I'm just curious.
I work in a rural county, just general practice.
Okay.
Don't do any criminal law.
Okay. Look, you have to challenge your brain on a daily basis. If that means doing your own research, doing your own case research, trying to remember lists. People have heard me say this, but I played bridge online. I played every night. I played a rubber almost every night that I was on hormone therapy for 2.5 years, only because I really wanted to try and remember the cards that are gone. And I think that really made a difference. But what you've got to be doing is you've got to be challenging your brain on a regular basis. Once you stop doing that, it goes downhill. So I strongly recommend, and if you can do it in the course of the work that you're doing in your regular, practice, law practice, that's great. If not, you've got to find a way to do that with Sudoku, crossword puzzles, playing games online, whatever it is. But it is so important. And I think if you do that together with some regular exercise, you're going to notice an enormous difference. I mean, every one of these guys that spoke to you right now all have the same complaints, and they didn't know what to do with themselves in order to make themselves feel better, just like you. And we got them to make changes, and now they'll give testimony. So we'd like to see you do it.
Okay.
Okay. But
that man plan is an excellent way to get started because it's graduated. It doesn't, you don't overdo it. It's hard to overdo it if you follow the directions. And then you can move on from that, because I did it until my bands all broke. And then I had to move on to doing other weights and resistance stuff and aerobics. But it's a good way to start.
So if you need support, let me know. I'll tie you into Dennis. He'll give you some support, and we've got other guys, but just reach out to me and let me know. And the only place you don't want to talk about exercise is on the inner conversation, because they'll encourage you to have another beer and sit, in your armchair. Don't ask Jake Hannum or Jet Teisberg about exercise. It's not a good idea.
You notice I've been very silent, Rick.
I
sign of your guilt.
No testimonies from that side.
That's right. That's right. That's right.
Shreff already knows. He's joined us several times already, so he knows how we are. Listen to Rick, not us.
All right, but Trev, thank you for those words of encouragement to Larry, and
thank you.
It's great when we get new guys who don't know which way to turn, and they hear some of these testimonies, and we'll be there for you. We'll be there for Larry, and we'll try and bring you through as best as we can. We still have another 10 minutes. Shreff, was there anything else?
No, thank you.
Okay. And was there anybody who wanted to say anything else to Shreff before we move on? Okay. Peter, I'd like to touch base with you, and I'd like to touch base with let me touch base with David Sibley first, and then we'll give you the last 5 minutes, Peter, to talk about this call. Actually, I need 2 minutes as well. David,
Rick, we also have Ken on the phone. I don't know if that's Ken Anderson.
Oh,
and we also have Rory. Did you touch base with him?
I did, but Rory's mic isn't working.
Oh, that's right.
And we have, is that my buddy Ken Anderson?
Yeah, I'm just here listening. I'm good though.
Okay. All right. Well, are the family back, or are the family away?
No, they're still here.
Oh, but I thought they were going on a trip and leaving you at home.
Well, they're back.
Oh, okay. All right. All right. So, and there's nothing you want to bring up, Ken?
No, I'm good.
Okay, great. David, you are trying to get onto this ES 414, is it, or 404 trial?
414.
414, right. Which, for those of you who haven't heard about this, is an immunotherapy trial where, in the simplest terms, you get an infusion that is given to you constantly, so you have to wear a belt. They tried to do this by doing it every 3 days or 4 days or longer. It didn't seem to work. So now they're going to have you wear a belt with a pump, and it will be constantly pumping this infusion in. And the idea is that this infused material, this ES414, is attracted both to the surface of the cancer through the prostate-specific membrane antigen, and also attracted to the T cells. And once it infiltrates both the cancer and the T cells, it acts like a magnet and pulls the T cells to the cancer. And the trial's been around a while, 2 to 3 years, but now they are changing the way in which the drug is administered. And David is a candidate for this at UCSF. It's also being done in 4 other centers, including Roswell Park, which is where Professor Bill is treated. And David, tell us where you are in that process.
Well, prior to starting the trials, I had to have a PET scan, CT scan, and a bone scan. And I could do that at my local hospital. And then this week, I go to UCSF for an EKG and some blood work. And then they will, if none of those tests disqualify me, then I will be moving on into the trials. And that will start April 4. And you explained it quite well. It's a continuous drip with a pump. I'll have to go to San Francisco twice a week to get the medication replenished. What happens is the very first week when they infuse me, I stay 2 nights in the hospital for observation. Then the following week, they're going to escalate the dose, and I'll spend 2 more nights in the hospital. And if everything works well, then they'll send me home, and I will be on that rotation of 2 visits a week to San Francisco for testing. And I think they're still going to use the PSA as a guide to whether this is working or not. And I'm still collecting information as we go along. So does anyone else have any experience with the trials?
With any trial, you mean, or
are trials similar to this, or in phase 1 of this ES414 trials?
Right. I know there's no one else that's looking at the ES414. Possibly Eric May with Agawall if he doesn't get a result out of the carboplatin and Jeptana. But does anybody have any experience with a phase 1 or a phase 2 trial? So I guess not. David. I know the only thing I know is that with the phase 1 and phase 2 trials, that they are a lot more attentive, and I think this is a phase 2 trial because they're trying to come up with the right dosage for
right. They're trying to get the maximum safe dosage.
Right, which is a phase 2, which is the definition of phase 2. Well, look, and what are you actually doing right now? I mean, you're on your LHRH, Lupron, or whatever it is. Are you?
I am. I'm Lupron, and it's been like 3 years. Lupron once a month.
Right.
And I noticed you talked about a time limit on Lupron. My urologist is where I get my Lupron shot, and we never said that we should only do this for X amount of months.
Right. I made the caveat, the statement, maybe you missed it, that is only for people that don't have metastasis and who are being treated with Lupron as the initial form of treatment. So it's a little different to your situation where you had recurrent disease and you got put on Lupron. That's the difference. It's a very distinct difference.
I do have the fatigue issues and joint pain. I have started taking a pain medication, Tramadol, and that seems to work. And I only take 1 or 2 a day, and not every day.
And you're taking Tramadol for pain?
For pain, yes.
Okay. Is there anyone else that's used Tramadol in here? Is Tramadol an opiate, Len?
I don't think it is.
It is. It's an opioid derivative. It's one of the weaker ones, but it is.
Well, Len, maybe you could help me out because I heard this phrase. It was an opiate-like medication. And also I was told that it would be less constipating than a Norco or one of the other stronger painkillers. So
Yeah, probably because it's a weak opiate derivative.
Okay.
I should just add very quickly that Len is a retired pharmacologist, research, and then later a prescribing. I don't know, what do you call when you're not a research pharmacologist but you hand out the goodies? What do you call that?
Pharmacist, but I was not a pharmacist. I was a pharmacologist.
Pharmacologist.
Research.
Right. Research pharmacologist. Okay.
According to Wikipedia, they say it's similar to morphine, used for moderate to moderately severe pain, often used in combination with paracetamol or acetaminophen. I think Tramadol is more like used in Europe more so than around in the United States.
Okay.
Well, it's been in the U.S. for a long time.
Okay.
David?
And well, Len, maybe you could help me then. Is a Tramadol, it could be taken as needed? That seems to be the way I use it. I don't use it on a regular.
Yeah, sure. I mean, whatever, of course, you should follow your physician's instructions in how to take it and when to take it.
Oh, correct. Yes.
Yeah.
Has the physician suggested you take it as needed, David?
I think, well, no, actually, I think they've got it down to every, 4 to 6 hours or 6 to 8 hours.
Right.
I'd have to look at the directions again.
So, I would strongly recommend that you send him an email and ask him, can you use it as needed?
I will do that. There is some questions after tonight's visit. I do have a couple questions for the doctor. That's
great, sure. Great. All right. Well, look, we're at the witching hour, and Peter, forgive me, but you and I will talk about this, and maybe we'll give you some time next Tuesday. But before we hang up, I do want to just take a moment to remember Frank Kelley. I usually do this at the beginning, and I guess we were joking around, and I didn't mention it, but Frank was a very interesting and a very unusual man, and I had the privilege of actually meeting him, which with a lot of you I haven't been able to do. And Frank was an enigma. He lived in a very rural place, I think east of Coeur d'Alene, Idaho, in the middle of nowhere. So the virtual support group was a perfect venue for him, except he didn't want to be part of it. Fortunately, he had a wife who was very interested in learning and participating online, and who has become very, very knowledgeable. And Lisa and I started corresponding back in 2014 when I was pretty active on Inspire. And it took us quite a while, but eventually, I mean, she sent me an, oh, I think we're going to get Frank on the call, and then he wouldn't come on. Oh, I think we're going to get Frank on the call. Eventually, what happened was Frank called me, and so he finally agreed that he would talk to me, and we talked to him forever and a day. And Frank was never the most effusive and optimistic of people. So when he got on, all he wanted to tell me was he only had 12 months to live, and he was very concerned about how he was going to take care of Lisa and leave her in the middle of nowhere, and how is he going to get rid of all of his gun collection and this collection, that collection. I'm not kidding. I'm not kidding. And you know, and here was I in the middle of in Marin, California, in the middle of sort of liberalism. As it turned out, his sister-in-law also happened to live in Mill Valley, which was very convenient because she deposited a very nice bottle of single malt scotch on my door one day from Frank and Lisa. But eventually he got comfortable, and eventually he started participating regularly on this call, sometimes always with Lisa in the background, but sometimes with Lisa talking. But as he got more and more comfortable, we heard less of Lisa and more of Frank. And the 12 months turned into more than 4 years. And we tried to help him in many different ways, and he stopped attending this call probably about 12 months ago, but he attended the Inner Conversations call, where he was their resident Eeyore. I mean, I used to refer to him as Eeyore, and then I told Jake, and Jake liked the analogy, so they referred to him as Eeyore. Jake, did you refer to him as Eeyore to his face?
Oh yeah.
Okay.
It didn't offend him at all. I think it did at first, but he got used to it. And believe it or not, you know, Sylvester and Gary will attest to this. But believe it or not, he'd come out of his shell, and he started telling jokes, and he was a real party guy in his day, and he would tell some pretty raunchy jokes. He always said at the end that, like you said, he always said, oh, I've got 3 weeks, or I've got 6 months, or whatever, and we always try to talk him out of it, and hang in there, try this, try that. But he always invariably he would say at the end, says, I feel better at the end of this call, and I love you guys. And in fact, Lisa told me that he wanted. Lisa sent me an email, telling me he couldn't talk for the last few days, but that he wanted us all to know that he loved us as brothers.
So
that's nice.
Thank you.
Makes me cry to think about it.
Yeah.
I'm familiar with Eeyore as a character on Winnie the Pooh, but I don't know anything more than that. Why did you refer to him as Eeyore?
Oh, because Eeyore was totally depressive, and there was always, in all the drawings, there's always a little black balloon or a black cloud over Eeyore. And so,
Thanks for noticing.
Right.
And he had a real deep voice. Eeyore has a deep voice, and so did Frank. He was really a deep baritone.
Yeah.
He would talk slow and measured.
He was a wiry, thin guy. There's a lovely picture of him that we put on our in memoriam page.
Yeah.
And I also want to thank those of you who have made a donation in Frank's name. But the one thing that complicated his treatment immensely was that he had significant gut issues, which preceded his cancer. So it had been difficult for him for quite a long time to, he had to be careful what he ate and just keeping the food inside of him. And, when I met him, he was probably 135, 140 pounds, and he went down to 90 pounds. And that always complicated his treatment. But we will miss him a great deal. And I think that everybody associated with Answer Cancer can feel that they made a difference to his life. And that's why we're here. And that's why we do what we do. So, all right, guys, the next call will be, when will it be, Jake? The 27th?
No, I don't know what day it is, but it's next Tuesday, not tomorrow, but next Tuesday at 6 o'clock Eastern time.
Right.
Yes, it is. It is the 27th.
Thanks.
Okay.
Thanks. And don't forget, we have a caregivers call tomorrow. We have an inner conversations call on Wednesday. And then if any of you know any men who are dealing with breast cancer, we have a male breast cancer call on Thursday. It is a fantastic group. And, you know, unfortunately, men with breast cancer tend to get overlooked significantly. And just mention it to them because it's a really good group. Okay. Good night, everybody.
Good night.
From the new guy, thank you very much.
Pleasure.
Good call, Rick. Thank you very much.
Rick, thanks. I will send you an email, if not tonight, tomorrow.
Super. Super.
All right, thank you.
Good night.